Well, good afternoon, everyone. It's a little after the top of the hour, and we are so excited to have you here today for the Hunt Institute's Early Efforts web series. We're going to be underway in just about a minute or so. We'll give everybody just a moment to get into the room. But in the meantime, invite you to jump directly into the chat. Let us know who you are and where you're tuning in from, and get to know one another. So the chat is should be open and ready for your comments. Introduce yourself, and we'll be underway here in just a moment. You've got to be a fast reader for this chat. Welcome, everyone. It's great to see so many of you from all around the country. All right, well, as you continue introducing yourselves in the chat, we'll go ahead and kick things off. It's so good to be with you. My name is Dan Worry. I'm the Senior Director of Early Learning at the Hunt Institute in Cary, North Carolina. If you are joining us for the very first time today, the Hunt Institute is the creation of our founder, a namesake, four-term North Carolina Governor Jim Hunt. We are an education policy support to the nation's governors and state lawmakers and other senior state elected leaders. And our work covers the full spectrum of education policy from prenatal on up through the workforce. But in this, our Early Efforts series, we focus on the early childhood portion of that continuum and are so excited to welcome a really terrific panel today to discuss equitable birth outcomes, which is such an important topic that needs much more attention in this country. As I'm sure you know, pregnancy and the weeks and months following birth are absolutely critical periods for both mothers and infants' health and wellness, but we also know that not all mothers and babies experience this period in the same way. There are long-standing and well-documented disparities in our healthcare systems that have increased the risk of negative outcomes for some mothers and children, and particularly for mothers of color and their infants. And the data sadly bear this out in some cases very dramatic ways. To help us to understand more about how we can be working to promote equitable birth outcomes, we are joined today by three experts in the field. Megan Simmons is the Director of Policy at the National Birth Equity Collaborative and should be with us here in just a moment. We are also joined by Stephanie Spencer, who is the Executive Director of Urban Baby Beginnings, which is based in Virginia and serves 4 Virginia communities, and Celeste Sanchez-Lloyd, who is Program Manager of the Strong Beginnings Healthy Start programs. Panelists, it is such a great honor to have you here with us. Before we turn to our conversation, I want to mention a couple of our standard housekeeping items here at the beginning. First is that later in the hour, we will turn the conversation a little bit over to you. And so we'll invite your questions for the panel. If you have a question, invite you to enter that in the Q&A function down at the bottom of your Zoom screen, and would ask that you sort of be mindful to keep that separate from the chat. As you can see from the chat already, it can move very quickly and have lots of conversation across the hour. And so using that Q&A function helps us to sort of distinguish between the ongoing conversation of the group and the specific questions for the panel. So if you will use the Q&A, it is down there in the Zoom toolbar at the bottom of the screen. The other thing that you will find in your Zoom toolbar is the closed captioning controls for Zoom. Zoom. We are delighted, as always, to make this webinar available with closed captioning. And so if that is a service that would be helpful to you, please feel free to avail yourself of it. Again, you can find those settings in the Zoom toolbar at the bottom of the screen. Finally, want to mention to you that you will be able to find the recording of today's webinar, like all of our webinars, on our website and on our YouTube channel in the next couple of days. All you need to do on YouTube, go to YouTube, enter Hunt Institute in the search menu, and that should bring us up to our channel. You'll be able to rewatch this session, but also revisit all of at least many dozens of past sessions, not only in the Early Efforts series, but other programs that you may find valuable from the Hunt Institute. So great to have you all with us, and we're going to go ahead and kick things off. I know Megan is having some connectivity problems, so we will have her with us here hopefully in just a couple of minutes. But maybe, Stephanie, maybe we turn to you to kick the conversation off. As the executive director of Urban Baby Beginnings, I mentioned in Virginia, you work to reduce some of the adverse outcomes that I was mentioning in our opening, and empower families and address systemic barriers in care for pregnant and parenting families in Virginia. Share a little bit more about the work of Urban Baby Beginnings and the importance maybe of the services that you offer.
Sure. Thank you for having us, Dan, and Hunt Institute. We're always so happy to come and talk about the work and, to share the voices of our families and our programs and in the state. As Dan mentioned, my name is Stephanie Spencer. I'm the executive director and founder of Urban Baby Beginnings. I'm a registered nurse by trade, so I do have a public health background in that space. Urban Baby Beginnings is a 28-year-old nonprofit organization that works with pregnant and parenting people. And when we first started, we were really in the early childhood space. So we had a center-based program where children from the community could come in to get care and education during the day. So that was from 6 weeks all the way up to 5 years old. And what we really found was, as we continue to work with families in the community, that there were really a lot of needs that they had that weren't necessarily being addressed in the early childhood space. And so in talking with our moms, talking with our families, we felt very passionately about bringing the care model that we had into the homes. And so we actually closed that center-based program and moved it into what you see today, which is a maternal health hub that provides pregnancy and postpartum and early childhood support to mothers, birthing people, and their children in the state of Virginia. And when we started, we had one location in Richmond. As you mentioned, we are headquartered in Richmond. And since that time, we've actually expanded into 3 additional locations. So we're in 2 regions of the state. And our hubs are really safe spaces where birthing people, mothers, and their children can go to get the help and services that they need. And what we recognize is that there's a clinical component that is extremely important, right? So when people need care, they need to be able to get providers, they need to, be able to have prevention strategies that help to avoid hospitalization and long-term chronic illness and those types of things. But there's also a social factor that we fail to recognize a lot of times, and that social factor also has to be addressed in a community-based setting. And that's what Urban Baby Beginnings does, which it kind of marries the two. It partners with organizations, clinical settings, hospital systems, and others, and then families get the care and support that they need through doulas, community health workers, and other specialists who work towards having healthy outcomes along with the family themselves. So it is really important, we know, to have social engagement, and then to also work with people who can provide advocacy and resources as well, whether it be through crisis intervention or from a prevention space as well.
And Celeste, let's turn to you as well. You are a program manager for Strong Beginnings in Kent County, Michigan. And as a federal Healthy Start program, your organization has really promoted racial equity and worked to eliminate birth disparities between white families and families of color. Share a little bit more with us about the program and how it works and what impact it's had on the local community.
Yeah, thanks, Dan, and thanks for inviting Strong Beginnings. I'm so happy to be here with you all. Um, so Strong Beginnings, we received our initial funding in 2004 here in Grand Rapids and really focused on what was happening in our community. At that time, Black infant mortality rate was higher than any, in Grand Rapids was higher than any other city in the state of Michigan. And so at that time it was 22.4 infant deaths per 1,000 births. And so the community really championed together to say, there's an issue, there's a problem, and how are we going to combat this together? So out of that conversation, we've been able to expand since then into the Latinx community, and along with now serving as of recently refugee and individuals from African countries. So Strong Beginnings is a partnership of 7 community-based organizations, including 3 hospital systems, FQHC. Also, we have a mental health provider, one of our local universities, and then also our Community Action Network, which really houses our community voice. It's comprised of 85 volunteer voices of the community, really listening to what the community needs are in order to drive the efforts that Strong Beginnings does on a day-to-day basis. We are a home visiting program, really focused on maternal, paternal child health. We have a component where we've been able to expand to fatherhood. So we have male CHWs who are also conducting home visits. Our community health workers are really, they are the group. They are the real champions of the program. And they're working very close-knit to registered nurses, social workers, and our mental health therapists to provide services around goal setting, education, support groups, and really any resources or needed services that are needed with our families. And so, as I mentioned, we have our parallel program with fatherhood, which is also working very closely on male engagement and fatherhood figure participation. For our program, we really do count that racism is the root of where racial disparities begin. And so we've been focused on a catalog of services when it comes to dismantling racism. So between health equity, social justices, trauma-centered approaches, also within anti-racism and racial equity workshops, we've created modules working specifically with resident students around learning biases and modules that really focus on dismantling some of those biases that are created in the workspace. So that is a great amount of what we're doing here in Kent County.
So thank you. And I want to maybe circle back to a question and just flag that, Megan from the National Birth Equity Collaborative may or may not be able to join us, it appears. And so want to circle back to sort of where we were going to begin with her and let each of you sort of weigh in on kind of a framing question that we had hoped to kick the hour off with, because, I mentioned in the opening here that, that not all mothers are experiencing the perinatal period in the same way, and that the outcomes that, Celeste and Stephanie, as you both have referenced, bear out that there are some very dramatic disparities between the experience of mothers of color and their babies and other mothers. And, I think for a long time, it was something that was chalked up in some cases to differences in behaviors or other factors. But I think increasingly it is recognized as a problem with sort of implicit biases within the healthcare system. So want to give you in Megan's absence an opportunity, since you're both so involved on this topic. What would you share about, how would you describe to someone sort of the landscape of birth outcomes in the country, and what do you sense is contributing to these things?
We recently had an article that was shared in Virginia related to the increase in maternal mortality during the period of COVID, and it doubled and tripled in number. And what we know during COVID time, many moms were isolated. They were told, that they should not have the COVID vaccine. We went through all of these things. And so what we know is that there's a plethora of things that contributed to the increase of mortality rates for mothers and their children during that time, but it was something that was just compounded. It already existed. It was just much worse. I think that the landscape that we're looking at today, there's a plethora of things I think about. Yes, Celeste hit the nail on the head, when we talk about racism and just the history that we have over time and how we've created systems today. I always say when I talk about the work that I do that we've spent a lot of time trying to build the clinical piece of care. We have completely failed to recognize that the community as a whole doesn't necessarily engage in clinical care until there's an illness or there's a reason why someone needs to engage with a provider. And so we really structurally need to address the elephant in the room, which is that we are not providing the resources, supports, the living wage, all of the housing, all the things that people need to survive. And so when they're coming into a clinical space to get care, we're already at a deficit, which makes it very difficult, especially during pregnancy, because once you're pregnant, what we're trying to do is to maintain a healthy pregnancy. But if you're already entering into pregnancy with illness that has not been addressed or chronic issues and things like that, along with all the other social factors, we're already looking at the potential of having a difficult pregnancy or poor outcome. And so, with that being said, I want to make sure that we elevate the fact that we need to look at the community as a whole, the environment. We need to ensure that people have access to the resources that they need, but also too, that we're really enhancing people's lives by looking at all of the other structural things that people need to have in order to just be successful and to thrive in their own environments.
Yeah, I don't know if I need to add anything else to that. Stephanie really captured, a big bulk of what we were also experiencing here in Kent County, especially during COVID. As I mentioned, we work with Black families, but we also work with the Latinx community. And so we were having very similar conversations with our clients that they were living in multi-generational homes. Access to testing was difficult. There was language barrier to accessing vaccinations or testing. They were also working in many employer sites were not conducive to healthy living. Many of them were migrant workers. And so we had a lot of conversations around mothers who were fearful for going out, fearful for people coming in. We also had at one point individuals that were concerned about getting tested or getting vaccinated because of the fear of being deported. And so those were a lot of other stressors, right? We talk a lot around the livable wages, the low income housing that's not available because it doesn't exist anymore. Even affordable housing doesn't exist, right? And so being able to really think outside of the box with our community health workers, how do we make sure that we're addressing the needs of our clients and that we're getting them the proper access to care, along with just breaking some of these structural barriers that we have that are really circled around racism. And we were seeing that with our Black families also. So I don't know if there's much I can add to Stephanie's comment, but just saying that there was definitely a conversation around if we put these Band-Aid approaches during COVID, we're going to have these same outcomes in the future. And so how do we really dismantle what we know is causing this? And it's racism. It's practices that continue to lift racist practices, lift white supremacy. And so we've really have been having that conversation, which is why throughout the pandemic, we created in partnership with Michigan State University, these modules for providers, because we needed them to have an additional lens besides that professional lens that they tend to walk and see through.
And Megan certainly would have been a better spokesperson for this than I, but I mean, just, some of the data that jumps out off the page is that, that we know that the infant mortality rate, for example, among Black newborns is more than twice that of white babies during the first year, and that mothers of color die during childbirth more than 3 times as often as their white peers, and in part there's been some fascinating research, depressing research certainly, that suggests that that, for example, that Black mothers are 30% less likely to receive an epidural during childbirth, for example, and that that their perceptions of pain, for example, may not be as well acknowledged in the delivery room in some cases, and so lots of alarming data around this whole topic. Celeste, you were talking about the modules that
Right.
you all have put together. Several people in the chat have already asked about the modules and whether they're available, and what.
Yeah.
Tell us a little bit more about the modules and their content and how
Right.
they're accessible.
Yeah, so right now they're not open to the general public just because we're still working on them and just really fine tuning them. But they're 6-unit interactive modules really geared towards understanding racism and understanding bias around maternal health and maternal paternal health. So we walk through those modules. We walk through understanding implicit bias, making the connection between the role of the provider as doing their due diligence, that sometimes you have to advocate more than just what your professional license. It's more of the humanity of looking at each patient as they're coming through the door. And then also understanding the role that community health workers play and home visiting programs play, and how we can make sure that providers access the proper referrals, and that when they see that patient come in, they're seeing the entire patient. And Stephanie kind of hinted to this around not just seeing what that patient is there or has been told to come to see you, but really looking at what brings this patient in beyond just what's written on my chart, and really collectively working as a team. And so that's a lot of what we are stressing with our community health workers, with the other healthcare teams that they are integrated in, is how do we make sure that we're working on every front with the patient, and that the patient feels valued, they feel respected, they feel that they have a voice, and that they're being able to advocate for themselves. So our community health workers are really championing with them, and they're personal cheerleaders. But at the end of the day, we also want to make sure that this is not just the responsibility of the patient to advocate for themselves, but it really is the participation of the provider to advocate on behalf of the client or the patient. And so those 6 interactive modules are really engaging. It's not set up as a lecture. It's very much a facilitator and individuals walking through these topics one-on-one as a collective group and having that exploration. We want people to leave with an action item at the end. As a provider, we want them to be able to see themselves in more than just this role as a physician or provider.
And what sort of outcomes are you seeing from that, Celeste? Are you seeing providers sort of take action as a result?
Yeah, I think we've gotten a lot of great feedback from the resident students, and being able to have those aha moments, because if anybody who's been working in implicit bias or anti-racism work, this is not a start and stop. It's a continuum. And that's really what we're geared towards. So we are getting good feedback that people are enjoying it. It gives them those aha moments, and then also challenges them to really see what's next for themselves. Where do we continue to move as a provider, and then also for us as a program?
Stephanie, how does that sync up with your experience in Virginia?
As far as implicit bias and the training?
Yeah.
We actually have a bill that's out right now in the General Assembly that we're trying to push through for more education of providers and others in regards to implicit bias. We do think that it's extremely important, and we know that when people do attend these levels of sessions, it does improve the level of care that they provide. And so this is extremely important overall. So Virginia is making a push for ensuring that providers do go through this this level of education. And I think too, over the past couple of years, I think when I presented the last time with you guys, it was a couple of years ago, but we were kind of hitting the advocacy front in Virginia, talking about maternal health efforts and reducing maternal mortality rates and addressing implicit bias in systems. Mm-hmm. And so one of the things that we started to do was to really go out into the communities to start to talk to the moms and other people who had experiences within clinical settings, had children recently and just trying to understand what was going on in communities and what could we do to strengthen the supports. And over that time, what you start to see happen is that like-minded people and others start to come together to talk about what's happening. And just in that, it creates a frame of accountability for individuals so that when they go back into their systems, can really talk about it within their teams. And so not only between our Virginia Neonatal Perinatal Collaborative and the Maternal Quality Care Alliance, there are others that have all kind of come together to really talk about this. And what I've seen is for those that we've worked with over the several years together, that there really is a pivot towards addressing internally what's going on with me, but also internally within systems as well, and that there are champions that are working to change what we're talking about, which is that implicit bias does come into play when care is provided. And as a result of that, we're starting to see stronger partnerships, the identification of implicit bias immediately and being able to address that in a way that changes outcomes for birthing people.
Stephanie, what are you mentioned having those conversations directly with mothers, for example, not asking you to share anyone's individual story, but are there themes that emerge from those conversations that you would point to as sort of the experiences of these mothers in this area?
Yeah, I think there's a issue of believability, especially for women of color, and being able to present into systems. And if you don't look a certain way, you don't say something the right way. It's more of a, well, come back later. Everything's okay. You're just fine. Go on back. And then here we are back in the hospital a week later with something that's really much worse than what it was when they initially presented. And I do think that there are themes related to the lack of communication or the ability to communicate between provider and client and having the time to be able to do that. I do think, again, going back to the believability factor, you hinted towards pain and, the fact that when Black women especially are talking about how they're feeling or if they are in pain, they're not believed in that space as well. I can tell you and point you all to what you might be curious about. There's a maternal mortality review team report out in for Virginia. And there was one that was recently done, or at least in the last couple of years, related to chronic conditions and care coordination. These are things that our moms were already talking about. So a report just kind of brought it to fruition. But the reason why I bring it forward is to really kind of bring in why it's important to address, bias in systems. And this report talks about the deaths and what they were related to. And 15% of women who had a chronic condition had a facility-related factor contribute to their death. And facility-related factors, can be getting into the hospital system, having a lack of community outreach. We had 28% of community-related factors contribute to someone's death, and 51% of women who died within a 12-year period were related to a provider factor. And so when they started to look at these deaths, started to look at the fact that women weren't being referred and consulted with when there were other chronic conditions that needed to be addressed. There were individuals that had delay in treatment. And then also, when you look at all of this, it just lines the picture of what we're really talking about. And that document is available to the public. So you can see what we're talking about here, from an implicit bias standpoint of how it looks like on a grander scale over many years' time.
Stephanie, I just noticed in the chat, there's a question about citing that Virginia report that was.
I'll put it in the chat.
Okay.
I'll put it in the chat for you guys and you can go and find that. Mm-hmm.
Great. Want to encourage you, as I mentioned at the top of the hour, we are going to transition here in a few minutes into some of your questions that are down in the chat. So if you have questions, please do feel free to enter them into the Q&A. I want to ask both of you one more question maybe before we jump into those. As you are creating these policies and programs to help promote these equitable birth outcomes, in what ways do you engage the community? I think, Stephanie, you sort of already have alluded to the interactions with mothers, but how are the voices of families kind of centered throughout this process? Maybe Celeste, could we begin with you there?
Yeah. So as I mentioned, we have the Community Action Network, which is comprised of community members. We really are listening. So we engage our moms, we engage our families. We also engage open to community members who are just interested in maternal, paternal child health. We have our male participants. We want to hear what works and what doesn't work. We want to hear how the systems are working as it relates to healthcare. We also make sure to include our community voices, our families in when we conduct focus groups, we do interviews, we test everything through our clients in response. So any new form, document, engagement tool, we pilot all through our community members and our patients and our clients, really to make sure that we're meeting their needs. We do not want to do anything for clients or participants. We want to do it with clients and participants. We really want this to be community focused on our initiatives. And that's really why we love the use of having community health workers in our program. They're trusted individuals. They can work hand in hand with clients. And so it has been a great opportunity to really capture our participant voice. We've been able to have them in roles of leadership. They've been able to present at conferences. A lot of our community health workers were former participants. And so we just really try to continue to ingrain that community knows what's best. So often they're left from the table to being able to vocalize those needs. And so we're about creating space for community voice and really moving to the side.
Stephanie, anything you want to add? I know we already talked a little bit about how you've connected directly with moms here.
Yeah, something very similar. I think that one of the things that has been really important for us to share about Urban Baby Beginnings was that it was built by the moms within our programs. And they were, and over time, we continue to see the same, and we continue to engage them in how do we then move forth to improve outcomes and supports in communities. As Celeste stated, it's extremely important to not just build it, have this mentality of let's build it and they will come type of mentality. And it's also important to engage community members, because you may find informal structures of support that you didn't necessarily know existed, which is also extremely important, because as champions, we want to continue to push forth those efforts and to continue to support them as well. And so for us, from a state level, I talked about kind of what we've done across the state. There's more to that from a local and regional level. We definitely make sure that strategically every year that we go out and we do a larger report to go back through what our moms would wish for us to do within our program, operationalizing our program, and then also strategically with others that are in the community, such as providers and others, because we want to support them too. Again, this is a collaboration. It's not just it's multifaceted. And so everybody has to be at that table. And then I just want to end with what Celeste said, is that you have to open spaces at the table to ensure that the people that are impacted are there. And so we make sure that, that table is built so that everyone is welcome, because everyone's affected in this space, in the support of our maternal health hub, and then the efforts that we have across Virginia.
Great.
And Dan, if I could just add that an example of having community voice, we had a maternal health summit, and we brought community members and we brought participants and patients. And out of that summit, that's exactly how we were able to expand into fatherhood. There was a space that was not being filled, and response was, where's our dads? We know that they exist. We want to break this narrative that Black fathers don't exist or that they're not present. And so we decided, that's right. Why are we continuously, approaching this from a maternal child health standpoint, and we're leaving out a key ingredient, right, which is fathers. And so being able to listen to community and say, this is what community needs, and this is what their response is. So we're going to move forward with this decision. And it's been great. We've gone from working with Black fathers and expanded into the Latina community.
So let's say a little bit more about the role of fathers. What have you found is key, not only to their involvement, but in what way does the presence of a father or the connection of the father in this equation help to support better outcomes?
Mom just feels supported, right? And so we do a lot of teaching around that. You do not have to be in a romantic relationship with the mother of your child in order to be a great dad. And so really encouraging dads around how do you make sure that you know when the appointments are. We do trainings around how to wear your baby. So being able to do that skin to skin, wearing your baby. We're teaching some really unconventional topics that historically have been left out of fatherhood, making sure dads understand the value of safe sleep, and so that they can set up baby in a safe sleep space also when they're watching their children. And then also, how do you engage with mom? Right? Even if you're not romantically involved, how do you show support? What happens when mom needs a day off? How do you make sure that you have the proper tools and resources to maybe handle anger or frustration or stress? Also, a different avenue that we don't have a lot of conversation is when there's been a loss in pregnancy. And so how does dad recoup from that, making sure that he has access to mental health therapists and that he's able to also discuss his feelings and that it's okay, and normalize that conversation, especially for the community that we're working with. Our participants are often steered away from having those really difficult conversations around understanding postpartum depression with your partner or baby blues, and then also what in return does that look like for you as a new dad. So we're really engaging fathers in multiple levels. We have a Facebook group for them. We're doing Manhood Mondays. We're having conversations in barbershops, which are very untraditional, for talking about the entire experience from prenatal to 18 months after delivery. And just also family planning. We have that conversation with our fathers and making sure they understand contraceptives and the role that contraceptives play with their partners. And so to us, fatherhood is a parallel program. It's not higher or lower than our maternal side. It runs in the same vein.
I don't know if you saw, there was just a comment that popped up about the Manhood Mondays. Can you say a little bit more about what those entail?
Yeah, so Manhood Mondays, we do an hour session facilitated by our Fatherhood CHW and our Fatherhood Supervisor around various topics. This month being Black History Month, it'll actually have a Black father talking about his experience and his love and admiration for his children and how he's engaged in fathering his daughters. Also, he'll talk a little bit about how he was a stay-at-home mom or stay-at-home dad for part of the time with his children. And so it just gives you another insight, along with we sometimes have topics around career advancement, generational wealth, really breaking some of those stereotypes that come very close to our fathers. And so it's been a great opportunity. We get great engagement. We've had a lot of great acknowledgement for our Manhood Mondays, and they're very much approaches men's health. And so I'm really excited about the direction we've been going with those.
Love it. I want to jump into some of these questions, and I'm noticing there are actually several questions related to doulas in the chat. For the benefit of those who maybe aren't as familiar, or maybe even in their own experience haven't used a doula, Stephanie, can you help lay the groundwork maybe preliminarily on what is a doula?
Sure. So in Virginia, we promoted the use of community doulas for support and resources for individuals. So they provide physical, emotional, and educational support to pregnant and postpartum people up to the first year of birth. And really the goal is to provide a social support structure, non-biased system of support for people, and access to an individual who can help from an advocacy lens all the way up through helping someone to cope through their labor and birth experience. And then just being a trusted member of the community, being able to listen to what's going on with that mom or the partner, and helping to bring resources together and navigating through that system, in a communal fashion. It's really important to recognize for community doulas, the word, when I said trusted member of the community, that they're a reflection of the community in which that they serve as well. Because we know that when people are assisting others in their community and they're from that community, we tend to have better outcomes as well, because you can navigate better, you're very familiar with the system, people know who you are. And so we're trying to make sure that we're promoting that as well, through this space.
Celeste, anything you want to add on doulas? The associated question, maybe, and I can maybe you're able to weigh in on this as well. Associated question about how do doulas contribute to positive outcomes for moms, especially moms of color?
Yeah, so we've been fortunate enough to partner with some of our local organizations here in Kent County that are doulas, along with some of our CHWs have been trained as doulas. And so they really, to Stephanie's point, they really are providing that support, that advocacy throughout pregnancy, during delivery. For Michigan, I may have some Michiganders on the line. As of January 1st, Michigan Department of Health and Human Services has recognized doula initiatives as being reimbursable. And so that is an area now that we're looking into and just really partnering with. There's some gaps, and doulas have shown that they can be present in those gaps and they can advocate and they can lead to successful deliveries for families. And so we're really excited about that.
That is exciting. And the other, I don't know if either of you want to weigh in, and I feel like Celeste, you sort of hit on this, but the other doula question was sort of at the policy level about how can states and communities really sustainably incorporate this practice and ensure the availabilities of doulas. Certainly, it sounds like making that a reimbursable service through the state's Medicaid plan is a key part of that.
Absolutely. And I think that Virginia just became the 4th state to reimburse doulas under their Medicaid product. And that was quite a bit of time that it took for us to get through that process from a legislation standpoint for credentialing for our doulas. And then now we're in the implementation phase. And so what we know previous to Medicaid reimbursement, that many doulas were serving their communities for free, through bartering or low cost. And you really didn't have a systemic response to what we're really talking about, which is the need for social support and advocacy and resources for birthing people, and more specifically for birthing people of color. And so with the implementation of Medicaid, and reimbursement of that, that's one step towards ensuring that there is a foundation of support for doulas. But also I want to challenge everybody in states to recognize that part of that foundation is not held by just the doula alone, but organizations who are providing a structure for individuals for billing, for support, education, continuing education, training, and the like. And so I would love to see states put more effort as well into the reimbursement structure for the foundation that also needs to exist. And also not to forget that when we're talking about Medicaid, there's still a percentage of people that are commercial. And then there's also a percentage of people who are uninsured or underinsured. And so as a result, when we're trying to develop policies, especially from a doula perspective and a systemic solution, we need to make sure that we're addressing all ends of facets of reimbursement. So there should be a commercial reimbursement for doula support. There should be 12 months of postpartum coverage, inclusive of those who are uninsured. We need to figure out how to get them insured. And then the remainder of that is the implementation of, that systemic response, which is ensuring that people are reimbursed appropriately for the level of work that they do. I don't think that we're there quite yet in all states to ensure that doulas are reimbursed properly.
Stephanie, a question that I think in the chat relates to something that you had said earlier, so I wanted to throw this out, was asking if we could hear a little bit more about the difference between facility-related deaths and, was it provider-related deaths, the other category?
So you want to hear the differences between the two?
Yeah, please.
Mm-hmm. So in Virginia, when they were really looking at this report and kind of just trying to determine what were the differences in the deaths, a facility-related death is once I enter into a facility, such as a hospital system, such as a clinical system, there's something that happens that contributes to my death while I'm in that facility. So if I'm in the hospital and something has occurred, whereas maybe I haven't been connected to the appropriate services in appropriate time, that can get in the way of me having a healthy outcome. But on a provider level, that's a little bit different because you can also add things such as provider level from a community-based perspective. So in that instance, you can look at providers who may have provided care, I don't know, family practitioner who may have seen someone who was expecting and or an OB, and they ended up engaging with that provider, and then there was a delay or lack of diagnosis or treatment, or even follow up with that condition, which contributes to that person's death as well. I think that what we're trying to get to is, even in the years going forward, we're actually expanding the research that we have related to maternal mortality. And our hope is that we'll start to see year by year reports that will even give us more detail related to individuals' conditions. The other thing I wanted to add in regards to facility, which we see this now, and think about it from this perspective. When someone engages in a clinical system and there's a lack of coordinated care, so there's no care coordinator, there's no social worker, there's no coordination of benefits, nothing like that that's happening when that person is in an acute level situation, that also can fall underneath the facility related deaths as well. So the inability to facilitate care coordination within a facility can also contribute to and increases the chance of mortality in the postpartum period, which is where we tend to see most deaths. So without going too much in the report, that's what they're really talking about from a facility standpoint versus provider level, which it can be multiple providers that engage with someone who's pregnant.
Great. Another question in the chat, Celeste, and I think you mentioned that the modules that you all have put together sort of address this, but question as to what are some solutions in this patient-provider relationship where these implicit biases might occur? How do we go about making that a better situation?
Each module is like 8 hours, so but I think what we're really saying is to have that self-exploration. You really have to look at where you're starting at. And then as you're working with families and you're looking at patients and you're looking at what biases do you come to the table with, we're saying those may not all disappear and it may take a while. And so our point really is, how do you make sure that you recognize them? We want you to recognize them. And once you recognize them, how do we start working through some of those? How do we engage? And it can be something as simple as what kind of language are we using? Do we acknowledge when we say someone's name incorrectly? Do we use the proper pronouns? Do we acknowledge the father who might be in the room? Do we make sure that we're addressing all of their questions and we're looking at it from a step back and not just our questions for them? And so it is like I said, it's not a start and stop. And we try to make sure that the modules indicate that and that people understand that you really are taking each module as a self-exploration so that we can get to the best form of care we can with our patients.
Stephanie, anything you would add? There's a related question here about, what are the practical realities here in terms of but beyond obviously trainings, are there other ways that we can be working to reduce this implicit bias in the healthcare system?
Yeah, I think that advocacy is extremely important. I mean, just even recently for myself and my family went through a health scare, and there were advocates that were in that space that allowed for us to be able to find the voice to be able to move forward. And there were many times where there were places that we needed to be connected with, and just all these things going on. Everything was moving so quickly, but by all of us being able to come together as advocates and being familiar with the medical system and also having connections, it allowed for us to have a positive outcome, and it could have been very different. The only reason I'm bringing that up is because I feel like, yes, on a larger scale, people are trying to figure out, they're like, okay, yes, legislation, that's fine, but what can I do today? What you can do today is to make sure that you use your voice and use your connections and your tools to create safe spaces for birthing people. And so what that means is, if you find me on the street, I'm always talking to people about maternal health efforts. I want every mother, every birthing person, every father, every family to know what they need to do to survive in this system that I can't change right now. But what I can certainly do is I can certainly connect you to one of our hubs, and I can ensure that you have advocacy and tools and resources and information. I can mitigate some of these things that we see that are related to implicit bias and racism just simply by being a safe place for people to commune and by sharing my voice and support in these spaces as well. So I do think that every person can do something now. It doesn't change the larger issue of what we're talking about. It doesn't change the fact that racism exists. It doesn't change the fact that there are barriers that are in communities that people really, truly are trying to navigate through. But if we can all commune together, that helps to resolve this issue. I work with a group. I'm a chair of the Maternal Quality Care Alliance, which is part of the Virginia Neonatal Perinatal Collaborative, which is the PQC in Virginia. And one of the things one of my team members shared was an article talking about the wealthiest Black moms are more likely to die in childbirth than in the poorest white moms. And there's a study about this. And obviously what it's talking about is that there's no level, the high income does not protect Black women from having the effects of negative effects of racism. But one of the things she said, she pulled out of it, which I thought was really nice, was a statement, and it just made sense. It shared everything that we're trying to do here in Virginia. But it says, but for the Black women today, women living with the health consequences of racism and more, community level efforts are often the best way to reclaim a sense of power. And so that's what I want to challenge people to do, is to strengthen community-based efforts, because it is one way that you can change outcomes for the better.
Stephanie, you hit on another question that's there. I think you sort of answered it in your response, but this question around, isn't it the case that that even independent of income, that this isn't in these disparities, it's not necessarily a question of, oh well, more low income mothers, that even among mothers of color at very high incomes, that we are seeing these disparities.
Yeah, that's right. I mean, it didn't protect me from having a preterm birth. It didn't protect several of my friends from having poor outcomes. It didn't protect my mom from having a poor outcome. All of us have master's degree on up or bachelor's degree on up, and are in middle class to upper class incomes. It didn't preclude any of those things. So Black women are reaching in the pregnancy space and reproductive space in a different way. There's a lot of weathering that exists as a result of racism when you have to deal with this on a daily basis. And so we can't negate the fact that that's happening. We need to address our own selves on what's going on and hold people accountable. But also there is something to be said that there are protective factors by building community supports by community leaders and others who are trusted in these community spaces, and just creating a better sense of community overall. We cannot isolate our moms away from what's most important to them: family, friends, partners, fathers, and the like. And we can build protective systems that help to do that.
Question, or Celeste, were you going to?
No, I was going to say very much so. I was just going to add that I think what we're seeking is true, authentic allyship, and that individuals or providers and community members are going to stand up, use their voice for good, use their licensing for good, recognize when there is a disparity, recognize when there is an issue or concern, and not leaving it to be someone else's concern, not leaving it to someone else to handle it. We're really taking that allyship to a level of accomplice, right? We're looking for accomplices in this work so that they can truly be in the trenches, understand what our patients and our families are going through, and then say, this is where we recognize the barrier, and I'm going to do this with my level of power and privilege. It's using that privilege for good and being able to really make some disruption where needed.
That's great. We've got just a couple of minutes left. Christy has a really interesting question, though, that I think in the chat here that really pertains to both of your programs. She's asking whether you have found a way that you consider kind of a best practice or a gold standard in terms of making outreach into the community and actually helping mothers to access your services. She's sort of saying that, that home visiting, for example, can be a very effective strategy, but can also sometimes be kind of a tough sell to the people that might benefit from it. So what ways do your programs really work to make that outreach and to connect with the families that might benefit most from your services?
Yeah, so for our program, our community health workers are really great about being innovative. Also, we don't limit our home visits to in the actual home. We want to meet our patients and our families where they're at. And so that can be in a library, that can be wherever they've identified is in space, a safe space for them to share their experiences with our community health worker. So often, a lot of our families may feel that their homes are not appropriate for individuals to come in, and we want to respect that. We want to make sure that we're connecting. Also, our CHWs, as I mentioned, are innovative. They will stop anyone and everyone in efforts to make sure that they're well informed about how to navigate their pregnancy and delivery. And so we do that through health fairs. We connect with our local public school systems. We go to parent night outs. We go to parent teacher conferences. They're at the local clinics. They're going to the prenatal organizations that are working around advancement. And so just anywhere a CHW thinks that there may be a pregnant mom or a partner of a pregnant mom, we're going to reach out to them. We're going to connect with them. Like I said, our fatherhood program is being really innovative by using barbershops. We host friend of the court events so that we can engage with fathers there. And then we also are doing our social media push. We've seen a shift in generations also. So some of that conventional ways of targeting our families in the past, we've now seen a shift that people like to be texted and emailed, and they like social media platforms. And so we're really moving into that network also of how to connect with our clients and keep them engaged. And the COVID really pushed us to also visit telehealth. And so we've been very successful with telehealth in response to not having an actual individual in their home. And so we have a good percentage of our clients, even with the world's quote unquote opening up, still prefer telehealth. It allows flexibility for us to meet with patients outside of the normal 8 to 4:30 hours. And so we've had a lot of positive response when we're promoting the program with families and saying, we will meet with you virtually, or we can meet with you in person, however you feel most comfortable with.
That's great. Stephanie, anything you'd add?
Yeah, I mean, I think there's a lot of informal sharing of information. And so we really use ambassadors who have either gone through our training programs, participated in our programs as well, and then others to be able to share the word about the need for support, whether it be through getting support through classes, support groups, or directly from our programs. We really want to make it a community effort. And I do believe that it's important to get people to connected to early childhood programs, prenatal, postpartum program, any kind of program you can, but I also recognize that there's a larger percentage of people that don't necessarily do that. And so we also use more informal ways like radio. We just recently started this year with promoting on Her Story. We go into the communities and schools, they're called that here in all of the school systems, and we encourage those who have boots on the ground to engage with their systems as well, get out to the community to do door to door, to go and talk to them about having healthy outcomes. And we also, for every client that we engage in, whether it be clinically and they enroll with us and or not, so it can be hospital system, community-based system, or the like, all the things that Celeste mentioned, we still are providing resource education, and we're also providing a card, because we're saying you may not recognize today that this is something that you need, but you may recognize in 2 months that you might need the help, and we need you to either come to us, or we want you to share the card with someone else. And then lastly, just all the things that we're doing, I think allow for us to make generational change, because once you teach someone in a family how to advocate for themselves and what the system really looks like and how to maneuver through that, they can pass that from generation to generation. So the hundreds of people that we have trained, we've now impacted generations for a lifetime. So I think that those are also ways, just in the informal sharing and direct programmatic, as well as our trainings and resources, that we can reach other people and continue to do outreach.
Fantastic. Stephanie, thank you. And Celeste, thank you. We are just about out of time. It's right at the top of the hour. So want to thank Stephanie Spencer, who is Executive Director of Urban Baby Beginnings in Virginia. Celeste Sanchez-Lloyd is Program Manager at Strong Beginnings Healthy Start in Michigan. What a treat to have both of you with us. Thank you for taking the time to join in this important conversation today. And I want to thank all of you for tuning in. We'll invite you to join us again. We'll be back on March 7th talking about literacy, and in particular, the role of language and literacy from day one. A lot of states are spending a lot of time and effort focused on third grade reading proficiency, for example, but we recognize that language and literacy develop on a continuum that begin even before birth, believe it or not. And so we'll unpack that case for literacy from day one. Dr. Nell Duke of the University of Michigan will be joining us, along with Lori Masur, who is the director of Read On Arizona, and Dr. Dina Castro of Boston University. Looking forward to that conversation in March. And then in April, we'll be back with a conversation about promoting nature-based learning in the early years in partnership with our friends at Trust for Learning. They have an important report that is going to be coming out on nature-based learning, and we'll be excited to speak to some of the authors and some of the participants in that work as well. So hope you can join us for our upcoming session. Stephanie and Celeste, again, thank you so much for your time and for being here today, and we'll look forward to seeing everyone soon.
Thank you,
Thanks,
Dan.
everyone. Have a good
Thank
afternoon.
you. Bye-bye.